Delighted to have you. And you're joining an audience of about 40 people in the room here, many experts on your field, and an online audience too, so welcome.
Thank you so much. I'm sorry my commitments this week didn't allow me to join you in person. It looks like a lovely venue in a wonderful city.
We are very fortunate to be here, and we've been having 2 days of extraordinary discussions. And I'd love to start by asking you a little bit about the new center you've started at Tufts. So maybe you're a cardiologist, and now you've started a center that's about food and medicine, putting those two together. Can you tell us what was behind that and why you're doing it right now?
Yes, well, I think first thinking about the themes of this conference and agriculture and innovation, if farmers don't have a market to sell, they're not going to grow their crops, right? They need to have a stable, consistent market. And, the largest groups of missing foods in our food supply are those healthy foods that are more expensive, spoiled more frequently, are higher risk for farmers. Things, not only fruits and vegetables, but nuts and seeds and beans and legumes, ancient whole grains, other things. And we have shown that that's what's causing most of the disease burden in the world. So people think about food when they think about chronic diseases like diabetes or obesity or cardiovascular disease. People think about the negative things about food. They think about salt or sugar or too many calories or fat. But ironically, most of the disease is due to insufficient intake of the good things of the healthy foods. And so how do we get those foods to people who need them and create markets for farmers? One of the most exciting innovations that we've been thinking about for years, but is finally really moving and taking shape in the United States, is this movement toward food as medicine. And so food as medicine is the concept that the healthcare system, a doctor or another clinical provider, can prescribe food to their patients, and the healthcare system will pay for the food for many months or even longer, depending on their disease condition. And this sounds like a crazy idea, but it's actually happening now across the United States. Tens of billions of dollars are being invested by state programs, by government programs, by private insurance programs, by employer-based healthcare systems to pay for food for patients in need. And I can talk more about that, but our institute, the Food as Medicine Institute, is really leading in the research in this area, in the education and training in this area, and in the policy translation, importantly, in working with government and working with the major federal agencies and with Congress to move this field forward.
Thinking about primary care in the United States, which has been very neglected, and some other countries have primary care that is more invested in community care, how much of what you're doing is directed at issues that are peculiar to the United States, where chronic disease is such a burden, and how much are you seeing those issues spreading now around the rest of the world?
Can you repeat that? Can you repeat
I'm sorry.
the question?
Yes, I was asking about primary care and your issue of prescribing food, just as we see people now prescribing exercise. And in the United States, we know that primary care has been very neglected, possibly less so in some other parts of the world. So I was asking whether your center is focused mostly on issues that you're seeing in the United States, or whether they're global issues now.
Well, it's absolutely true that diet-related chronic diseases like obesity and hypertension and diabetes and cardiovascular disease are absolutely global issues. These are the top causes of death in almost every country in the world. And 20 years ago in my career, we talked about the epidemiologic transition or the nutrition transition, that low-income countries were going to shift toward chronic diseases and away from infectious diseases. Unfortunately, we can stop calling it a transition. It's happened. And so if you go to any major city in the world, hypertension, diabetes are killing thousands of people. Today, the rates of the prevalence of diabetes, the percentage of the population with diabetes in India and in China and in Japan is similar to the United States. So similar rates of diabetes in India, China, and Japan. So it's happened. So it's a concern everywhere. I think we are mostly focusing on the US right now because this is where all the energy is. The White House released a national strategy last year that incorporates food as medicine. Nine major states in the United States, including New York and Massachusetts, California, many others, are actually implementing food as medicine in their states. Major private payers, some of the biggest actually the biggest insurance payers in the country, some of them insuring 50 million lives, 40 million lives, are utilizing food as medicine. So the wave of energy in the United States is very large, and so we are working on that. At the same time, we are working in Australia. We have some partners at the George Institute in Sydney, Australia, and we are doing food as medicine in Australia. Some groups from Canada have contacted us and are starting to think about food as medicine in Canada. Someone from the UK Treasury contacted us and is interested about food as medicine in the UK. And interestingly, I had a wonderful conversation with the Minister of Health from Bhutan, and Her Excellency was very interested in doing food as medicine for diabetes in Bhutan, and so we've just started those conversations. So this is a very rare case where the U.S. is leading the rest of the world in something innovative in healthcare.
That's wonderful to hear. And I'm going to ask one more question before opening it to the rest of the people here. But how much can this approach help tackle those huge issues of health equity that are bedeviling the United States and other countries around the world now?
Yeah. Well, you mentioned a prescription for exercise. I think this is different than a prescription for exercise because it's not just a doctor writing on a slip of paper and then hoping the patient goes out and does it. These are companies, not large nonprofits, other vendors who have set up distribution systems where the doctor writes for fully prepared meals. If the patient's particularly sick, they can be fully prepared, medically tailored meals that match the patient's kidney function and sodium needs and other needs. Or they can write for medically tailored groceries, boxes of specific foods. The healthcare system pays for the food. It actually pays for the food, either some or all of the food. And then the food is often even delivered to the patient's home, removing barriers like transportation, time, and access. And so we are involved now in multiple studies around the country where we're implementing this. The most common populations are type 2 diabetes and high-risk pregnancy. Those are the most common populations, but people are also studying hypertension, heart failure, and other things. The reason I say that's important is, poor nutrition is really one of the top causes of health disparities. Around the world, populations who have lower incomes, less education, who have suffered from structural oppression, from prejudice or other things for decades, tend to have the worst food availability in every country in the world. And so these programs are exciting because it's the first healthcare innovation where not only we're targeting disease, but we're targeting social needs. And so in the United States, for example, if patients are food insecure or have financial strain and have difficulty shopping and preparing healthy food, those patients tend to be targeted more. And so this is really exciting because as a cardiologist, I've seen new ways to put in heart valves. I've seen new pacemakers. I've seen new ways to put in drug stents in coronary arteries and all of these incredible innovations. Many people in the room there may have benefited from some of those innovations in their own families. Those are terrific innovations, but they tend to go to those people who need them the most, the least. And here with food as medicine, what's exciting is the major focus is on patients with other social challenges and social needs. And so I think this is not the only solution. Obviously, there's other solutions around income and jobs and housing. But within healthcare, this is a solution that can actually start to reverse these health disparities.
Well, I don't want to hog the microphone here, and so I'd love to open up to questions around the room. I can see one ready for you now from Christopher Upton.
Yeah, thank you very much. Really fantastic stuff. I've got one of the slides that we were shown earlier had a graph showing incidence of obesity in populations in many countries, actually, and also amongst young people. So this is school-age children increasingly becoming obese. And I wonder at what point can we move away from treatment to prevention? And I'd just be interested in your views on that.
Yeah. Well, so I'm of two minds here in answering this question. So first, the food as medicine movement that I'm describing is explicitly treatment, not prevention. And so it is using the tools of healthcare, the doctor, the prescription pad, the payment system for treatment of diabetes, hypertension, other conditions. I think that's positive because healthcare wants to see results today, right? Payers want to see results today. Governments want to see results today. People don't have patience to invest millions of dollars for a return 10 years or 20 years from now. And so what's exciting about these food as medicine interventions is in these selected patient populations, given as treatment, these treatments not only improve health, but actually lower healthcare spending in many cases. And so it's one of the very few treatments that can improve health and lower healthcare spending. So from that side, right, it's good to talk about treatment and focus on treatment. On the other hand, at the end of the day, it's going to be more broadly efficient if we start young and have these, healthy food available to all. I think there, probably population level policies are more relevant than the healthcare system. How do you use school meals? How do you use government feeding programs for the poor? How do you use procurement? Major employers, governments purchase food for their cafeterias. For the meeting you're at today, somebody picked the food. Hotels. How do you use the power of procurement in major institutions to purchase healthy food? So I think that for prevention, long-term prevention, we probably need to turn a little bit away from the healthcare system today and toward population policies. In the future, maybe 10 years from now, even kids can get these prescriptions. But I think right now the focus is on patients with diet-sensitive diseases where you can see a return on investment, within 6 months or a year.
We have another.
Thank you very much. Very interesting topic. I don't have a question as much as I would like to just add a little bit to the topic, because we've actually been running at the Basque Culinary Center some interventions programs, culinary nutritional intervention programs over the last years. And we've had extremely good results from this. So for me, it's also a matter of cooking is medicine, because instead of just giving people a recipe book and telling this is the right diet for you, you should cook this at home, we invite them to our workshops where we actually teach them new culinary techniques. We teach them how to have more confidence in the kitchen while cooking. And we've seen great effects, especially we did a treatment program for diabetes type 2. And it really, the adherence to the diet is so much greater if they feel confident using the culinary techniques instead of just having a recipe book. And we've been running similar projects for seniors, for kids as well. So I think cooking as well could be a very, very good way of creating or treat and prevent a lot of diseases.
No, I agree completely. And most food as medicine programs include both nutrition and culinary education with videos, sometimes in-person cooking classes. Not all of them, they're very heterogeneous. These are happening all over the country. Some are being done by nonprofits, some are being done by for-profits. So they're very heterogeneous right now, but nutrition and culinary education does tend to be integrated into all these programs. And I fully agree with you. How important that is. Now imagine, John, if in addition to the programs you were doing, the healthcare system was paying for $50 or $100 a month for the person to go get healthy groceries to match the recipes, or delivering them to their home once a week. So they're just arriving at the doorstep. Imagine how much more powerful your programs would be if someone was helping, especially for low income people who are in your programs, right? Who they may get the knowledge but not have the financial resources. And so I fully agree with you. And this is why combining these approaches is exciting. And it's for me as a physician, I've been interested in food for 25, 30 years, and doctors usually just don't care or don't notice. But doctors are paying attention, which is also really interesting. Having a tool, having something you can prescribe is very powerful. And I'll just say briefly.
Recording in progress.
Leave it to other questions that we also should talk about the very expensive injectable weight loss drugs, which are sweeping the world and are extremely expensive, because those are actually a push toward food as medicine, because payers, whether they're government payers, don't want to pay for these incredibly expensive drugs for 40% of the population. And so there's also a movement there. But I agree fully with you, John. And as I said, try to start partnering with some healthcare systems or around you and see if they'll pay for food.
Daria, I have a follow-up for that, and that is to ask about whether medical schools are paying attention, and are doctors, young doctors, being trained about nutrition now? They weren't particularly well in the past, particularly in the States, but are you having an influence there?
Not yet at any scale. There are many individual medical schools which have created culinary medicine programs and culinary medicine curricula where medical students not only learn about nutrition in their coursework, but cook and touch the food and learn about the food. But this is a handful of medical schools around the country, not anything systematic. But the movement is there and the energy is there. And I'll point to two exciting developments. First, last year, the U.S. House passed an overwhelming bipartisan resolution stating that all training programs from medical school to residency and fellowship, and also what we call continuing medical education programs for current physicians, that all these programs must integrate nutrition education into their programs. And it was a resolution by the House, it's not a law, but the House resolution said, if you don't do this, we have ways to start taking away your funding, because a lot of medical education is funded by the government through grants and gifts and other things. And so it was a very powerful resolution. It put all the groups on notice. And then last year, President Biden and bipartisan leadership in Congress hosted a White House conference on hunger, nutrition, and health, which was the first time the United States has focused on nutrition and health in over 50 years at the highest level. And in response to that conference, the major accreditation agencies in the United States agreed to host a summit to talk about nutrition education. And so the association that accredits all medical schools got together with the association that accredits residency programs and fellowship programs. And I spoke at that conference in March, and we talked about the importance of making, the accrediting agencies are the ones that control the curriculum, right? Because the school has to get accredited. And one of those two, the ACGME, which accredits all medical schools and residencies, decided the next month and announced at a meeting that we hosted that in their next major update in 2026, they're going to make nutrition education mandatory for all residency and fellowship programs. So that's a huge, huge change. And so while I don't want to say it's happened yet, it is starting to happen.
That's wonderful. Phil Lader has a question for you.
You're typically all too modest. The White House conference would not have occurred, but for your having pushed, prodded, and initiated it and convinced President Biden to have it. And while this group is aware of your role in that, for those who are listening in the Spanish live stream, they should know that you also, with Chef Andres, was the co-chair of the White House Conference on Agriculture, Food, and Nutrition, first one in more than 50 years. I ask you, Dariush, what would this audience of Europeans be finding most surprising as a result of what was discussed at that conference, or what do you think will be the most impactful consequence of that gathering?
Well, so, when I came, I was a faculty member at Harvard, and I was recruited just within Boston to Tufts University about 10 years ago. And when I came, I learned about a French nutrition scientist named Jean Mayer, who had been the president of Tufts and founded our school. And I learned that Jean Mayer in 1969 worked with President Nixon and hosted the first White House conference on hunger, nutrition, and health. And that conference in 1969 was groundbreaking. It put into place all of the modern U.S. food policies over the next decade, mostly focused on addressing hunger. But it did things like school breakfast, expanding school lunch, the food stamps program, many other major innovations. And I learned about that conference in 1969, and this was 10 years ago in 2013. And I said, oh my goodness, it's been more than 40 years and we haven't had another conference. So we started working with the Obama administration then to try to see if we could get another conference. We weren't successful, but the Biden administration was excited about and willing to do this conference. And so that conference was supported by Republicans and Democrats in Congress. It was supported by the agencies. It was supported by the private sector, because people recognize, I think, after COVID-19 and everything else going on, that the food system is broken and not serving, Americans or the world very well. And so while it's still early and, we need to wait a few years to see what happens, there's already been incredible movement, Phil, from the White House conference. And so as examples, the Veterans Affairs hospitals, which serve all the nation's veterans, the major hospital system in the country, are now starting to implement produce prescription programs for patients. The federal government is going to, I think by next year, require mandatory food security screening in all of healthcare. So every time you go to a doctor's visit, you have to screen for food insecurity. There's Secretary Tom Vilsack, who's our Secretary of Agriculture, has said that we have to not only focus on food security, we have to think about nutrition security. How can people not just get calories, but most? And the private sector is also responding because they see profit. If you can make people healthier with food, profit. So I'm very optimistic over the next 10 years, if this continues, that this White House conference can have sweeping effects. At the same time, I'm not, and so I know that people like myself, leaders like leaders in the private sector, have to keep pushing our government to help support these policies.
Yeah, and we have another question from Julie.
Thank you. Thanks so much for such an interesting presentation. I was wondering if you are facing some resistance from the pharma sector, and how are you planning to face it? Because I can imagine that better health through healthier food will mean less drug sales, so you might have some resistance or not, maybe not.
Yeah, it's an interesting question. Before I answer, also mention that Ambassador Phil Lader hosts a meeting in the United States every year, and I think the first time I publicly talked about the White House conference about 3 years ago at his conference. so that was, I just was remembering that memory. Not yet. People have been fairly quiet. I think that there is starting to be companies in the United States that are thinking about how to use nutrition and lifestyle to keep people off these new weight loss drugs, the GLP-1 agonists, or once they're on the drugs, how to get them off the drugs. And the drug companies won't like that, right? They won't like nutrition and lifestyle being used as alternative. So otherwise, things have been quiet so far, but I do think if we start to see that nutrition and lifestyle can keep most patients off these expensive drugs or get them off the drugs once they're on them, pharmaceutical companies will take notice and not like it.
Interesting. I have another question.
Hello, thank you very much for being with us today. This is more an invitation rather than a question to consider Spain also as a country where food as medicine could be implemented. I say this because Mediterranean countries are usually not regarded as the countries or the region at risk, but this is not the case. Spain has the worst rates in terms of children eating vegetables, so it's the country in Europe where children eat least vegetables, and is the fourth country in terms of childhood obesity. So you may think that Mediterranean countries are in a good position. They are not anymore, so it's only part of our memory, of our history. So I would be willing to continue the conversation as to what can we do also in Spain to implement food as medicine.
You're absolutely right. And in the scientific world, we talk about the traditional Mediterranean diet. We don't say the Mediterranean diet anymore, because the traditional Mediterranean diet is disappearing, especially among people who are under 30. And so you're absolutely right. This is a problem around the world. And I would be delighted to work with academic investigators, hospital systems, anyone in Spain on this. It's amazing how quickly it's grown in the United States. And as I said, all major healthcare systems are actively talking about this, and tens of billions of dollars are being invested in this right now. And so I think it's a movement that's going to come to your shores, and you might as well help lead that.
We probably have time for one more. Did I see a question down there? One more question from the room before? I have a question if nobody else does, so I will take it because it leads straight off what you were talking about. And I wanted to ask about school meals and whether what you're doing now, even though it can have an impact on school meals, which vary enormously around the world, and some are of really pretty high quality, and others we see are of very, very poor quality. And you know, whether that's a starting place for some of the work you're doing with young, you know, to aim at young children.
Yeah, no, as you said, school meals vary widely, and so in some countries like Japan, school meals are treated as a sacred meal and incredibly healthy. In some places in Italy, I know that. In other places, there are no school meals at all, or there are school meals, they're very poor. We are focusing on school meals in the United States where we've done work, and the nutritional quality of school meals dramatically improved under the Obama administration because of a law passed in 2010 that was championed by then First Lady Michelle Obama that dramatically improved the nutritional quality of school meals. And we published a paper a couple of years ago showing that among all the places in the United States, food from grocery stores, from restaurants, from other places, school meals today are actually on average the healthiest place in the United States, which is kind of sad, but true. But there's still a lot of work to do. And so I think school meals are very important. It's again, one of these things that the first questioner asked about, you know, thinking about long-term prevention. It's hard to convince governments to support these policies that are so critical that we're not going to see a return on investment until 20, 30 years down the line. So I think we have to continue as a society to meet that case. Feeding our kids food has to be the top priority.
Dari, thank you so much for joining us, and really congratulations, I think, from everybody in this room and everybody listening online for this institute. And I didn't make clear, it only started in October, right? So this is new and fresh and very, very exciting. Food is Medicine Institute at Tufts. Thank you so much for joining us.
Thank you. Thank you so much.
Wow, that was